Here to the House Majority Policy Committee hearing. We are in great expectation of having some great testimony this morning as government continues to try to find ways to make themselves more efficient, spend money more efficiently, and hopefully save some dollars. We're hopeful that your insight can help us do that a little bit better. Some of my frustrations has been, government, state government specifically, spends millions and billions of dollars a year talking about trying to upgrade technology and bring things into the modern age, but yet I'm not sure the efficiencies are always felt as well as they should be. We know that data collection is, that we get through these different proposals sometimes isn't utilized the way it should be, and we're hoping that we can change that as we look at state government in different light than we have in the past couple of years. Personnel costs we would hope would go down as technology utilization gets better, but I don't see that, and government continues to grow. So without further ado, we will ask the members just to introduce themselves as we prepare for today's hearing. As the testifiers think about what you're going to present to us, I will throw out the question I ask my own staff often: if you were king for a day, what would you tell us would be our best steps to go forward as we try to make better efficiencies with government and use tax dollars more efficiently? With that, I'm going to ask the members from the right to the left, introduce yourself and where you're from, and we will get started.
I am Stephen Bloom, State Representative from the 199th District in Cumberland County.
My name is Lee James. I'm the representative from Venango and Butler counties.
Good morning. Matt Gobler, 75th Legislative District, Elk and Clearfield counties.
Representative Kerry Benninghoff, didn't know my own name, from Center and Mifflin counties. Welcome.
Good morning. Marcia Hahn, 138th District, Northampton County.
Good morning. Chris Dush, Jefferson County and Indiana County, the 66th Legislative District.
Ted Nasbitt, Mercer County and Butler counties.
Linda Culver, 108th District, Snyder and Northumberland counties.
Good morning. I'm Representative Kate Klunk from York County.
You are for the next 15 seconds.
Dave Zimmerman, 99th District, Northeast Lancaster County.
I believe we have two members to my far left.
I'm never to the far left.
I wonder if you picked up on
Representative Seth Grove, York County.
Representative Kristen Phillips Hill, Southern York County.
Thank you. As I stated earlier, we will have members that will come and go periodically, so please bear with us. There are competing voting meetings going on as well. We appreciate the media coverage. This is being videotaped, but I ask people to have their cell phones on vibrate and not be taking calls during the meetings if all possible. And our members that are not able to be here will be able to view this later.
It's a MedExpert. We have a 10-minute presentation. We are going to focus on the cost-saving aspects to the offering that we can provide, and obviously we'll have more information available to you. You have a PowerPoint in front of you. We'll only go through a couple of the slides of that PowerPoint. And then there's two documents, a CBO document, and then another document called When Evidence Says No and Doctors Say Yes. Those are with our packet. So MedExpert is a innovative health technology company. We provide total population health quality medical management system. We work with every single patient, and what we're here today is to show you what we've been able to do in the Medicaid space. Our mission since the first day has been to provide every man, woman, and child with current, unbiased, and accurate medical information. Based on that information, people are able to make better decisions and costs will drop. So to get to exactly what we do, in 2014, we responded to an RFP for the state of Alaska. They called it care coordination for their Medicaid population. They handed us a large group of their Medicaid recipients, and we started working with them on January 1, 2015. At the end of 2016, we reported results. They reported the results. So if you go to the page that just has Alaska Medicaid results, this gets to the heart of what we were able to do. So in 1 year, of providing telephonic and electronic support to their Medicaid members. We were able to drop their emergency room utilization by 25%, and we dropped their entire budget for that group by 14%. This is unheard of, and this has been reported now to CBO. It's been reported to the National Governors Association, because part of the RFP was funded by the NGA. More specifically, some of the savings and where they came, we dropped outpatient dollars by 26%, inpatient decreased by 15%, professional services 21%. We increased pharmacy claims by 0.7%. Waivers were increased by 2%. Mental health decreased 5%. Tribal clinics decreased 14%. Transportation services decreased 14%. And then the rest of the list, this is sorted by percent of total budget, and the rest of the list has increases and decreases. For instance, one of the things we always seem to do is increase hospice. But we usually, if we ask someone, you know, how would you or your loved one wish to spend their days, we've yet to hear anyone say, I want to go to the hospital. They usually want to stay at home. So we provide all the mechanisms to be able to execute that. The reason there's a blue bar on inpatient is that we have found in our book of business that inpatient is the highest predictor of what the overall savings will be. So in this case, we dropped inpatient services by 15.56%, and the total decrease in budget was 14%. Alaska is a fee-for-service state. So what we also want to do, if you go to the next page, is identify what we were able to do in a United Healthcare MCO environment. So we were, in 2012, there were 3,500 companies that applied for a CMMI grant. We were one of the 107, and we received the grant in the space called shared decision making, which is the essence of working with a person you're helping make decisions. The part of the grant required that we work with United Healthcare, and so we were handed 10 regions across the United States. That was 144,000 lives. We executed the exact same service, which is, when you talk about total population health, quality medical management system, you're really a patient-centric program that you commonly hear in different buckets: care coordination, case management, disease management, patient advocacy, patient navigation, biometrics. All of those things are really the same to us under just quality metrics. So in this environment, this was, again, a third-party report of our experience. So with the 144,000 people, we dropped acute inpatient admissions by 17%. Skilled nursing facility inpatient admissions were dropped 17.9%. ER visits dropped 2% in this population. Outpatient surgery dropped 15%. Primary visits dropped 1%. The third example we're going to provide is where we started as an organization. We started roughly in 2000, and we started in the Taft-Hartley and commercial business. So the third page you see is Taft-Hartley results, and the importance of that is this is a 10-year evaluation of what happens when we're in place for 10 years. So we started with them in 2007. It's roughly 130,000 lives. They spend less for healthcare today than they did 10 years ago. And it has nothing to do with cost shifting. It's because we're able to address the individual on a case-by-case basis, and we reduce demand for services. And the reason you want demands reduced is because we have so much unnecessary care going on in healthcare. I mean, one of these articles, When Evidence Says No and Doctors Say Yes, this is written by David Epstein, who was a senior Sports Illustrated articles. So it's wonderfully written, but it shows, for instance, everybody knows that in a stable patient, 50% of all stents that are put on are absolutely medically unnecessary. 19% of all back surgery should never have been done. Then there's another whole section that is maybe. Mammograms in anyone younger than 50 basically is medically unnecessary, and the list goes on and on and on. So what this 10-year study shows is that if you teach people to deal with current, unbiased, and accurate information, you can actually build logic into their decision-making, and they reduce demand for services. Now there's on the very right side, you see a letter D. That D is significant because in this population, 22,000 people in this population were part of Medicare. So when we were having 2 independent federal groups auditing and evaluating our CMS work, they looked at this 22,000 and they said, we have to kick them out of the study. We asked why, and they said because they're too healthy and they don't apply. So this was the best news we ever had. It started like a negative conversation, but we said, well, how much healthier are they? And they said they're drastically healthier. So that showed us in a 10-year experience how you really can long-term affect the care. So in these 3 charts, we have the commercial business. That's a 10-year study. We have the CMS work, which is 3-year, and then we have the 1-year results, what we can do right out of the box with the Medicaid population. The beauty of our platform is that it works regardless if you're in Medicaid, Medicare, or commercial business, because a person acts like a person. You give them current, unbiased, accurate information, you deal with it in a very fast way, you satisfy their need for information, you help them navigate the system, and you'll get costs out of the system. I'm going to divert from the PowerPoint and just kind of say why we do what we do, and to make sure that we stay within your 10 minutes, and I appreciate that. So how we got and why we work. In the 1970s, I was a bench scientist in leukemia research at Stanford. If you came to our lab and another set of labs, you could go into first remission. We published feverishly going, why aren't, we just have a protocol. Why isn't the world able to understand that it's just a protocol? So I thought maybe it was just hematology that wasn't able to stay up with the times. We published in all the leading peer-reviewed medical journals, but it wasn't a problem just with hematology. It wasn't just a problem with oncology. What we found is that there are brilliant people all over the world constantly publishing work, but the point of discovery to point of care is 7 to 17 years. So we got together with some very bright people in the 1990s and said, is there anything we can do about this? This is prior to MedExpert. This is more just looking at this incredible trend of delay, because if you're working on data that's 7 to 17 years old, that is why in healthcare now you have a more than 50% error rate. So we tried to figure out, well, how do you get to the evidence? So manually, we would comb through the evidence, and you've got AHRQ and others who've done the same thing, 800 hours manually to comb through the peer-reviewed medical journal's information to get an answer. We had the convergence of a technology. We had 2 technologies, artificial intelligence and supercomputer computing. We moved to Champaign-Urbana, home of the NCSA supercomputers. And what we were able to do, and this again is just prior to any MedExpert, is we were able to take the 400 to 800 hours and engineer it down to 4 to 8 minutes. Now we knew we had a starting point. We had that golden nugget. We had the ability to base decisions on evidence-based medicine. Then what we did was make sure that we were extremely efficient. So we put together an electronic health record system and then a telecommunication system. And with our evidence-based medicine system we call FAME, with our electronic health record system and our telecommunication system, we knew that we could be part of the solution, not part of the problem. And that was our goal. This article by the CBO identified 30 such programs such as ours. They called them, again, the names are care coordination, case management, disease management. They evaluated them in a hospital setting, clinic setting, telephonically. And here's what they found out. All 30 of these programs that the CBO evaluated, they were able to reduce that dollar. They were able to affect a change. But all 30 of these programs, it cost $1 to save $1, which meant that it really wasn't progress in terms of trying to affect a financial impact. What we're able to do is you spend less than a dime to save the dollar, and how we do that is through technology. So in our offices, if you were to call us in less than 0.25 seconds, we know who you are. In less than 1 second, you're automatically routed to your case coordinator. In less than 2 seconds, 2 large screens with all your information come up. Our average person in-house can go to resolution on 150 transactions a day. And they have the knowledge underneath it to support it. That's in comparison to most systems that you can go to resolution on 7 or 8. So that's not magic. What that is hardcore engineering of technology to make sure we're efficient and effective. And that's been our goal, is to make sure that we're part of the solution long term, not part of the problem. So what we believe that we can do for the Commonwealth is equivalent to any of these 3 examples. We believe, and we were asked yesterday if we had a crystal ball, and Representative Benninghoff, you said if you have a crystal ball and you address the Medicaid population, what could you do? And we believe, based conservatively, we could reduce costs by 8 to 15%. Using this methodology, because it's a win-win for everybody. Nobody wants to have an unnecessary back surgery if they never needed one. You certainly don't want to have a knee revision if you could have gotten the first knee replaced properly. So you don't want 2 surgeries if one is good. You don't want 1 surgery if none is indicated. You don't want to be on 10 meds if you can optimize it at 3. And then another trend that we have found repeatedly is people no longer want to go to a hospital or a clinic if they can get cared for at home. And this is another advantage of technology. There is so much that technology allows us to do. So in closing, the question is, well, what's it take to get your system up and running? And because we're so technology-based, we could be up and running in less than 30 days from receiving base data. We could start and address your entire population in less than 90 days. So those are my remarks. I believe that we will be asked questions at the end. And thank you for this opportunity.
It's a lot of good information in a short time. Mary Ann, did you want to add to that or anything?
No, I'll join with questions.
Very good. We appreciate that. Very helpful. Some alarming numbers there, but our members will continue to ponder that. I'm going to start off with Representative Bloom. One of our committee members. Also want to acknowledge that the Appropriations Committee has some members here, Representative Grove to my left, and some of their staff who's been working very hard on cost-saving measures as we continue to balance our budget, and I'm honored that they joined us for the hearing and wanted to thank them publicly for that. If I may, informally, David, Kay, Mary, thank you very much for being here. Representative Bloom.
Thank you, Mr. Chairman. And my question's for Mary. Mary, you mentioned, and I thought this was really intriguing, that you anticipated, I think, if your system were implemented on the Medicaid program, potential savings in the range of 18 to 20%?
8 to 15%.
8 to 15%. Okay, I didn't quite get the numbers, but I know the Medicaid program is huge. It's one of the biggest cost drivers in government. It's a partnership program between state and federal taxpayers. Can you give us, just for frame of reference, and just looking at Pennsylvania, if we could actually save 8 to 15% on Medicaid costs, what kind of dollar figure are the taxpayers looking at saving?
So we actually ran some analytics last night on it, just some pro formas. We've got your government, you have some things that you published, and then you have the governor's figures, but roughly, regardless of who's paying the bill versus FMAP, or it's roughly at 8%, it's $2 billion.
Thank you very much. I just wanted to to get a scope of what kind of dollars. I figured it was going to be big, so potentially like
And to
2 million,
support-
2 billion. I mean,
And to support that, the general belief is that healthcare does exactly twice as much as it should.
Wow.
That literally half of all procedures are medically unnecessary.
Wow. Thank you.
That was probably one of the most outstanding comments I heard you say earlier that really kind of jumped on me, and 50% of error rate in healthcare's decisions. And one of the things I've said about healthcare in general is when we talk about reforming it, we as individuals have an inherent responsibility to reforming ourselves and how we live our lives and whether we choose to smoke and how we eat and exercise. And unfortunately, how do you deal with a society who feels that unless something's happening to them or procedures being done, then they're not really being treated?
Well, you're putting your finger on that second article, that when evidence says no and
Yeah, I tried to brief it, but I want to listen to you. I'm looking forward to reading it.
You have to counter the impulses of the system. And we do that by providing them on any given day. We can address all 22,000 conditions, all 150,000 comorbidities, and we can generate 220 million unique reports. These reports are customized to the individual. So there's general background, and then there's some hard-hitting data. We're great believers in fully attributing our information and sourcing our information from peer-reviewed medical journals. So Representative Benninghoff, what we do is we counter the impulses that would occur in a physician's office with deep discussions, thorough discussions, heavy information in the sense that there is no doubt that what they're seeing is evidence-based medicine. They can literally source through every single attribute if they wish. And then, for instance, we routinely have conversations where someone says, well, my back surgeon said I need surgery. And then we'll provide this information, and one of our doctors, nurses, or information coordinators will spend all the time they need to go through it, because we don't have a time limit on that part. Then they may get to one of those classic studies that shows that, of the 30,000 people reviewed, 5 years after surgery, 5 years after not having had back surgery, they're in exactly the same place. Then there's usually this querying, like, can that be true? And you have other articles in this compendium that show that that is the fact. Of course, then the conversation usually routes to, well, then why does my doctor want to do this surgery? And that's when you say, well, they are a surgeon. You don't go to a butcher and ask for cake. You're going to get partially what you went there for. And physicians are so well-meaning, and they do a great job. But they, too, drive the process to doing something. So it actually takes a bit of strength to counter that impulse to want to do something.
I appreciate your candor on that. I feel that's part of our problem with the opioid addiction here in Pennsylvania as well, that people are wanting something, and so we're giving them, and we all want to have pain-free lives, and nobody wants to suffer. I'll pass over to Representative Grove. I know his question. I assume Representative Dush. Thank you.
Thank you very much. Very interesting. I go back to $2 billion in savings.
Billion.
Billion, yeah. It's a big number. Most of our policies we see in Medicaid reduction, we're looking at 1% to 2% across line items. So are you benchmarking that against Alaska results in Alaska? What states are you benchmarking that off of?
We're benchmarking it against Alaska, Medicaid, the Medicare CMS work, 3 years of work, and the 10 years of work where we had longitudinal analysis on the Taft-Hartley group, who does pay less today than they did 10 years ago.
Okay. Alaska, they're capitated, they utilize MCOs.
Alaska's fee-for-service.
They're fee-for-service, all right.
Second example was part of United Healthcare. CMS and United Healthcare selected 10 H regions. They were all part of the Medicare Advantage group, so they were in a capitated structure. But their decrease of utilization of care was actually the same as Alaska.
All right, so you have, can you send me the results of the capitated, the United Health?
You have them on the second page.
Okay, second page of the slide. Based on our MCO and our capitated, generally I heard your analysis, and it always goes back to why we're already doing this, right? I mean, that's the general conclusion. It looks like you're targeting super utilizers generally who are overutilizing the system, as well as trying to target kind of doctors to verify if you actually need this surgery. And it looks like from your data, you're pushing people more to x-rays and preventative care to verify before they go into maybe higher cost. Is that kind of how your analytics are working?
Actually, because of the strength of our technology, we are able to deal with every single problem that occurs. So we don't actually go one way or the other. We let the evidence dictate what to do. So for instance, our nation, we do 10 billion lab tests a year, which is crazy. They're ordered, too greatly ordered. So we certainly don't advocate going and getting a lab test if you know nothing, you can't do anything with the results. We don't target super utilizers. There's some interesting data that it's basically regression to the mean data. But if you spent a lot of money last year, so you know that 10% drives 80% of your costs, okay. So if you look at that population year 2, regression of the mean will usually mean that that group will actually only drive 18% of the cost. So you can't, a chronic super utilizer, you can affect a change, but you can't corral people who are spending a lot of money and think that you're going to build efficiencies just focusing on a subset, because they either regress to health or they go the other way and they're no longer an issue. So our strategy is that we contact everybody at least once a month. Our telecommunications system can make 3 million calls every half day. Our efficiency on how we answer and work with people makes that an easy part. We have no voicemail. We have no phone trees. From the time you call till the time you speak to someone, on an average, and we monitor this, is less than 7 seconds. So it's about reaching out with everybody, trying to intercept when someone may actually start driving costs, being there to divert a behavior. We do, for instance, with the state of Alaska, we're now involved in 4 state initiatives. We can analyze the data. We know who is taking opioids. There's no secret. And so we're working with the state, as we could work with the Commonwealth, on what themes. They want to tackle 4 themes in the year. They want the DEA work to surrender prescription drugs that are found in the house, opioids. They have dental issue with children. So we work with them on these health initiatives. We can all look and find who we're supposed to work with, but what we're able to do is within a day, we can call everybody and on a one-on-one basis actually make whatever that initiative is hit home into that person's house. Again, using current, unbiased, and accurate information. So we can target, to your point, we can target populations throughout the year. But what we also have to do is once a month make sure we have really good mind share and build credibility and trust with members, that if they work with us, they're going to get the real information.
This question is for each of you. Being on a probe, we have constant IT issues in the Commonwealth. If you're not familiar with the UC Center, they're trying to do a modernization on a mainframe that's like 30 years old. I mean, there's a point where you just have to put it out to pasture, retire your old system. So my fear is we're taking this new technology, build it on top of an old system. We have agencies that do not talk to begin with. My understanding is the governor wants to merge those IT departments together. To me, that's dollar signs, not savings on the front end, because they already do not talk to begin with. So how are you going to manage your IT infrastructure built upon a very broken system across agencies to try to basically coordinate care amongst a lot? You know, we got carve-outs for MCOs between behavioral health and regular. So what's your strategy coming into our state that is very perennial in our IT departments, and how do we make sure we actually save money, and what are the upfront costs in trying to, at this point, trying to probably pigeonhole new technology on top of probably some very old software?
For us, it's not a problem. We take a standard eligibility fee to start the program, and that's why we can implement within 30 days. We've had to deal with dirty data entirely. It's just a straight mapping. Mary Ann Mason is Senior VP of Medical Informatics, does it morning, noon, and night in terms of taking in data. The more data we get, the more we can provide back, but it never stops us from working with the members and getting started.
Thank you. Good question. Before I go to Representative Dush, I just want to say that I'm sitting here, and as you begin your testimony, the more information you give us, the more questions we now have in our heads. We may end up calling you folks and doing some, what do you want to call it, interactive dialogues by phone, conferencing with the policy committee, because I know we are running out of time today, and I know more questions are going to come up. So we appreciate it, and I hope you'll be amenable to that. Representative Dush?
Yes, Kay. Okay, that's what I wanted from you. Mary, when you say your clients that are calling in, how many seconds again until they're actually talking with somebody?
On average, 7 seconds.
And you've got 2 full screens of data up there already on everything related to their health care?
Yes.
We are so out of whack with our state systems, and you guys have just proven where we need to be. And I brought this up in Labor and Industry Committee. The most robust system we actually have in the Commonwealth is the PennDOT licensing. It's built on the old Lotus approach and domino system. Everything else in JNet, which is a joint network of law enforcement, can crash, and somehow the PennDOT licensing system is still up, and they can pull up the old driver's licenses from the 1980s. We've got the data. We need to be able to transfer it over into systems that, just for a couple $1 million instead of hundreds of millions of dollars. I thank you very much for this information. I hope other members watch this and see where we need to go, as well as some of the secretaries of our different departments, to get a real grip on where we need to be and what the real costs for implementing this type of IT, the reasonable costs are. Thank you very much.
Thank you, Representative.
Well, you folks have been wonderful. We appreciate your work in the packets you put together and your staff being supportive here. I'm going to close us out with the same question and kind of open it up. If we were to put an RFP out tomorrow and you folks wanted to take it, and I said, well, it's your shot here. You're king for the day. You look at our Human Services Department in the state of Pennsylvania, it's about over $10 billion minimally in costs. What would be your last sales pitch to me? If you give us this contract, what kind of savings? I'm appreciative of the human savings and efficiency and good utilization and access to care. I don't want to minimize that, but at the end of the day, we're going to be making some decisions also on the bottom dollar line. Anyone have a response? Thank you. Okay, anything else?
I mean, we use IT to provide the service that we provide. So back to the crystal ball question, I mean, year one, we're pretty comfortable we could drop your Medicaid costs by 8 to 15% with a fully executed service. Our fees are on a PMPM basis. We compete with, if you looked at that CBO article, they said the average case management, disease management service costs roughly $180 to $350. In fact, in the state of Alaska, we're in the $4 to $5 range. The second RFP behind us came in at $190 PMPM. So year one ROI was 50 to 1. We expect ROIs 12 to 24. And again, that's because there's so much unnecessary work being done. So huge capability of cost savings and wellness. And I think that's one thing you would ask, that we really focus on the dollars, but we actually focus on doing the right thing for the member. And we took the gamble as a company that said, if we do the right thing and we don't speak cost to a patient, we gambled the entire company on, if you say and do and promote the correct thing to do, that the costs will actually come out through decreased utilization, improvement, quality, and all of that. And that's borne out in the decade and a half.
Well, you're each very bright individuals. We appreciate that. I heard that similar message in different ways from all of you. I can't thank you enough. I think the committee is both humbled and honored to have you here and have your testimony. I want to thank your staff for joining us. This does conclude the Majority Policy Committee meeting for today. We will be back in touch for other questions. If there's anything else you want to